Hey everyone, welcome to Cardiology 305 with Dr. Fernandez. Today we're diving deep into something mind blowing, the cardiopulmonary connection. How your heart and lungs are secretly best friends, or worse enemies, when things go wrong. This isn't just textbook stuff, it is the reason why one bad cough can stress your heart, or why heart trouble makes you gasp for air. Stick around because by then you'll understand your body like never before. Only for educational purpose. Let's get into it. By the end of this video, you'll be able to explain the hidden partnership between your heart and lungs, spot how diseases in one wreck the other, master the latest 26 guidelines on COPD, heart failure, and pulmonary embolism, and learn practical ways to protect both systems. We're talking bidirectional chaos, smart diagnostic, game-changing treatments, and why this knowledge could literally save life. Sounds good? Hit that like button if you are ready, and subscribe. What is the cardiopulmonary connection? Picture this. Your heart and lungs are roommates, crammed inside your chest, sharing everything. Blood shoots from the right heart straight to the lungs for a quick oxygen refill. Then powers the left heart to fuel your whole body. They're mechanically linked, hemodynamically sync, and even talk through inflammation and nerves. Disrupt one, and the other freaks out fast. This is the cardiopulmonary continuum, the ultimate dynamic duo, until it's not. Normal physiology of cardiopulmonary interactions in a healthy body is beautiful teamwork. Every breath changes pressures inside your chest, tweaking how much blood returns to the heart. You have respiratory sinus arrhythmia, your heart rate speeds up when you inhale and slows when you exhale. That is your body optimizing oxygen delivery like a pro. Ventilation perfusion matching keeps everything efficient. It's like a perfect choreographed dance until disease crashes the party. Mechanism of heart-lung coupling. Here's how they stay coupled. Mechanical forces from breathing squeeze or relax the heart. Hemodynamic shift move blood volumes around. Inflammation spill over from lungs to blood vessels, and your autonomic nervous system throws in sympathetic overdrive. Oxidative stress and endothelial dysfunction are the common villains. Think of it as a married couple. When one has a bad day, the drama affects both. Global burden. Why the connection matters. Let's talk numbers that hit hard. Ischemic heart disease killed nearly 9 million people in 2023. COPD hits over 223 million adults and caused millions more deaths. The 2026 Gold report screams that cardiovascular disease is way more common in COPD patients. Why? Because these systems don't operate in silos. They drag each other down. This connection explains a huge chunk of global suffering and why we need to treat them together. Bidirectional relationship, COPD and cardiovascular disease. Here's the vicious cycle. COPD ramps up your risk for hypertension, coronary artery disease, heart failure, and arrhythmias through shared enemies like smoking, pollution, and systemic inflammation. Meanwhile, heart disease floods the lungs with fluid and causes post-capillary pulmonary hypertension. The 2026 Gold report highlights this big time. One moderate COPD exacerbation can spike your risk of a major heart event in the next 30 days. It's not one-way traffic. It's a two-way highway to trouble. Pathophysiology, COPD effects on the heart. COPD doesn't just wreck your airway. It attacks the heart. Chronic inflammation and oxidative stress damage blood vessels lining. Hyperinflated lungs squash venous return and crank up right ventricular strain. Low oxygen and high CO2 cause pulmonary vessels to tighten. Result: endothelial dysfunction, platelet activation, and higher chances of heart attacks or irregular rhythm. Your lungs are literally stressing your heart out every single day. Pathophysiology, heart effects on the lungs. Flip the script. When the left heart fails, backup pressure congests the lungs, causing edema and making breathing miserable. Reduced cardiac output starves the lungs of proper blood flow. Atrial fibrillation or valve problems make it even worse. It's a classic vicious cycle. Heart troubles turns your lungs into a swamp, and suddenly every breath feels like a workout. Heart failure and lung disease interplay. Heart failure with preserved or reduced ejection fraction often teams up with COPD or interstitial lung disease. The combo multiplies symptoms and hospitalization. Recent 2025 reviews show complex mechanisms where each condition amplifies the other. Core pulmonary, right heart failure from lung disease is the final boss. Treating one without the other is like fixing only half of the problem. Pulmonary hypertension in the cardiopulmonary axis. Pulmonary hypertension sits right at the heart-lung crossroad. Group 1 is primary vessel disease, hammering the right heart. Group 2 comes from left heart problems. Group 3 is driven by lung disease, like COPD. Inhaled treprostinil is now approved for group 3 with ILD. The right ventricle eventually fails if the pressure stays high. Proof that lung issues can destroy heart function over time. Acute pulmonary embolism, acute cardiopulmonary failure. Now, for the emergency drama. A big pulmonary embolism suddenly blocks the lung blood flow, spiking right ventricular pressure and causing obstructive shock. The brand new 2026 ACC Guidelines introduces a 5-category system, A through E, to classify severity more precisely. Hypoxemia plus heart strain is acute cardiopulmonary collapse in action. This is where that connection becomes life or death. Diagnostic approaches. Integrated evaluation. You can't diagnose one without checking the other. Start with a history and physical, then 12-lead EKG, biomarkers like BNP for heart strain or D-dimer for clots. Checks X-ray, echo for right ventricular and pressures, and spirometry. Point-of-care ultrasound is a game changer in the ER for acute shortness of breath. Always think heart and lungs together. Advanced diagnostic for cardiopulmonary interaction. Level up with echocardiography, focusing on RV function, cardiac MRI for tissue details, cardiopulmonary exercise testing to see how both systems perform under stress, and even right heart catheterization. The stepwise approach nails the diagnosis in over 90% of cases by stage 4. This tool reveals the hidden interaction that separate good care from great care. Management principle, integrated cardiopulmonary care. The golden rule, stop treating heart and lungs separately. Hit shared risk factors hard. Assemble multidisciplinary teams, cardiologists, pulmonologists, rehab specialists, and keep the patient at the center. Multimorbidity is the norm, so smart, integrated plans win every time. COPD management in patients with cardiovascular disease. Smoking cessation is still the number one. It helps both systems instantly. Get all your vaccines to prevent exacerbations that could trigger heart events. Use LABA and LAMA bronchodilators carefully. Add ICS when needed. Supplemental oxygen save life when O2 drops below 89%. And pulmonary rehab is gold, but sadly underused. Heart failure management in patients with lung disease. For heart failure with reduced EF, start all 4 foundational drugs early. ARNIs, beta blockers, cardioselective ones in COPD, MRA, and SLG2 inhibitors. These work across ejection fractions and even help lung indirectly. In the heart failure with preserved EF, especially with obesity, semaglutide or tirzepatide can be game changers. for symptoms and weight. Balance fluid carefully so you don't drown the lungs or dehydrate the heart. Pharmacologic consideration in comorbid disease. Be smart with meds. Prefer cardioselective beta blockers in COPD patients. Weigh risk of inhaled steroids. Anticoagulate properly for AFib or pulmonary emboli. And remember, pulmonary arterial hypertension drugs are usually not for group 2 or 3 unless specifically indicated. Drug interactions in these patients are real. Always reconcile the list. Acute PE management in cardiopulmonary context. DOACs are the go-to for most pulmonary embolism. For massive high-risk PE, category E1, systemic thrombolysis can be life-saving, though bleeding risk exists. When systemic lysis isn't safe, go for catheter-directed or mechanical thrombectomy. The 2026 guidelines strongly recommend PERT teams for complex cases. Extended anticoagulation depends on your risk factors. Pulmonary rehabilitation, bridging heart and lung. Pulmonary rehab isn't just exercise, it's a full program of training, education, and behavior change. It reduces dyspnea, boosts exercise capacity, improves quality of life, and cuts hospitalization. Cardiac rehab overlaps beautifully. Integrated programs for patients with both conditions are the future, and yet less than 5% of eligible COPD patients get it. We need to fix that. Biologics and target therapies. For severe asthma, overlapping with high risk, biologicals like omalizumab, mepolizumab, dupilumab, or texepelumab cut exacerbation by 30 to 70%. Inhaled treprostinil helps pulmonary hypertension linked to ILD. We are moving toward therapies that target shared inflammatory pathways, treating the connection, not just the symptoms. Prevention of cardiopulmonary disease. Prevention is powerful. Eat real food. Move 150 minutes a week. Quit tobacco forever. Control blood pressure below 130/80 and manage lipids. The 2019 ACC AHA guidelines still hold strong. Catch comorbidities early in COPD or heart failure patient. It changes everything. Cardiac and pulmonary rehabilitation synergies. Both rehab programs emphasize supervised exercise, education, and lifestyle changes. High intensity interval training supercharges cardiorespiratory fitness. The overlap means we can design smarter combined programs. Multimorbidity and the cardiopulmonary continuum. Most patients aren't just heart or lung, they're both, plus diabetes, obesity, depression. The 2022 ACC pathway says prioritize patients' goal and life expectancy. Use drugs with dual benefits like SLG2 inhibitors. De-prescribe when possible. Integrated care models that treat depression alongside physical disease work wonders. Special population, the elderly. Elderly patients often present atypically, have frailty, and juggling polypharmacy. Titrate meds slowly and review the list often. The connection becomes even more critical. One system failure cascades faster in older bodies. Special population, women. Women face nearly 3 times higher odds of heart failure with preserved EF and have a unique risk for pregnancy complications, early menopause, and autoimmune diseases. They are often undertreated for both heart and lung issues. We need better recognition of this difference. Racial and ethnic disparities. Black adults experience higher rates of heart failure at a younger age, with worse outcomes driven by hypertension, diabetes, and social determinants. Equitable screening and care are non-negotiable if we want to close this gap in the cardiopulmonary connection. Health equity and social determinants. Screen every patient for social determinants: food insecurity, transportation, financial strain, support system. Barbershop programs have dropped systolic blood pressure by 22 milliliters of mercury. Build multidisciplinary teams with the community, health workers, and train everyone on culture, competency, and bias. Palliative. Palliative care in advanced cardiopulmonary disease. Palliative care isn't given up, it's smart, early integrated. Manage refractory dyspnea with opiates when needed, focus on communication, advanced planning, and quality of life. Use it along curative treatment, not instead of them. End of life considerations. When survival drops below 6 months, consider hospice. Have clear protocols for deactivating devices like ICD or BAT that match patient values. Provide psychosocial and spiritual support for the whole family. Dignity at the end matters as much as fighting at the beginning. Future directions. Looking ahead, better phenotyping of heart lung interactions through multidisciplinary clinics, research, and share inflammatory and metabolic pathways, wearable tech with cardiopulmonary coupling analysis, and truly personalized medicine that treats the continuum. The future is integrated and exciting. These slides pull from the absolute latest Global Burden of Disease Studies, the 2026 Gold Report, the brand new 26 AHA, ACC Pulmonary Embolism Guidelines, ACC AHA Heart Failure Guidelines. All sources are in the description for you to explore further. That's the cardiopulmonary. That's the cardiopulmonary connection in a nutshell. Two organs, one epic story of partnership and peril. If this blew your mind or helped you understand your symptoms better, smash that like button, subscribe for more medical deep dives, and drop your question in the comments. Which part surprised you most? Heart or lungs? Let me know. Thank you for watching. Stay curious about your body and take care of both your heart and lungs. They're in it together.